It's my honor to introduce Tamara. So Tamara Duker Freuman is a New York City-based registered dietitian with 15 years of experience in clinical gastroenterology, specializing in the dietary management of digestive symptoms and diseases. She holds a master's degree in clinical nutrition from NYU and completed her undergraduate education at Duke University. She's currently employed at New York Gastroenterology Associates and lectures nationally at academic conferences on dietary management of digestive disease. Tamara is also a nationally known health writer and the author of 2 books, The Bloated Belly Whisperer and Regular, which have been translated into 5 languages and published in over a dozen countries. She's also written close to 300 articles for U.S. News and Health Reports, Eat and Run blog, and currently serves on their medical advisory board. And with that, it's my honor to pass it over to you, Tamara.
Thank you, Jocelyn. Thanks for inviting me. There's a lot of you here. So I'm just going to not look at that number and dive right in so you don't make me nervous. Um, so the agenda for today is we're going to kind of take a moment and really just focus on understanding IBS, pathophysiology, diagnostics, same exact thing for SIBO, and then kind of moving into the interplay between the two, the overlap, how do we tell them apart because they can look so similar. And then all of the dietary management options for these patients who can be sometimes really hard to feed. So we'll jump right in and starting with IBS. So just to ground us all in the diagnostics and the definitions, IBS is a DGBI, a disorder of the gut-brain interaction, which really is characterized by abnormal sensory and motor responses to normal stimuli, whether it's spice or distension of the bowel or bulk and roughage, whatever it is, the gut perceives things in a very hypersensitive way, almost like the thermostat is sort of set to a very sensitive setting. The visceral hypersensitivity or pain is really what differentiates IBS from just plain old constipation or diarrhea or bloating. It's whether you experience those things as exceptionally painful is really what makes regular GI symptoms diagnosable as IBS. And it's considered a functional disorder, which is to say it's not primarily an inflammatory disorder. You see, I threw a little asterisk in there because, there's so much research going in on IBS right now, and we are starting to understand some of the mediators of this visceral hypersensitivity, what makes somebody with IBS experience so much pain. And we're starting to understand that histamine is actually one of the mechanisms by which people with IBS experience a lot of pain. And where does the histamine come from? Partly from mast cells, which are inflammatory white blood cells, which, some studies suggest maybe people with IBS could even have more of in the gut. And so while it's not primarily an inflammatory disorder by any stretch, it's not Crohn's, it's not inflammatory bowel disease or colitis, it may not be purely accurate to say that there's nothing at all inflammatory going on there. At least, not at the subclinical level. It's not I've ruled everything real out and you have IBS. IBS is a positive clinical diagnosis. Once a doctor has just ruled out IBD and celiac disease, a doctor can make a positive clinical diagnosis based on the Rome 4 criteria. And you don't have to check for 100,000 things before diagnosing IBS. It is not a curable condition to our knowledge, but it can be very manageable. We have tons and tons of management options, ranging from medications to diets to behavioral health interventions, which I will summarize momentarily. The Rome 4 diagnostic criteria for IBS are listed here. As you can see, the standard for any IBS diagnosis is abdominal pain. You have to have abdominal pain that is associated with disturbances in bowel function. The pain is related to defecation, whether it's I feel more pain when I have to go and the pain is relieved after I go, but sometimes it's I feel pain after I go. And generally it is also associated with a change in the frequency or the appearance of the stool, harder, softer, more frequent, less frequent. But really remember, when you think of IBS, you think of pain. That's what makes IBS-C different from just chronic idiopathic constipation. That's what makes IBS-D different from just chronic diarrhea. So how does IBS present clinically? A variety of altered bowel patterns, diarrhea, constipation, these weird cycles of constipation, constipation, constipation. followed by a day of diarrhea. Often with IBS-D, we see the mornings being a really active time of day for people where they're back and forth to the bathroom 3, 4, 5 times until they really kind of, the spasms stop and then they feel empty and safe and they can leave for the day. We often see an accelerated gastrocolic reflex. In other words, the bowel is very jumpy and responsive to the stimulus of eating. So often people are saying, after I eat anything, I have to run to the bathroom, especially worse with high fat meals or larger meals or bulky roughagey meals like salads. On the flip side, with IBS constipation predominant, we see harder stools. Often we will see a cycle of like nothing, 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 and then what I like to call a dam breaking day, where finally after 4 or 5 days of dribs and drabs, it's like finally like the bowel wakes up and then they make up for a lot of lost time. They start pooping, and then by the 4th or 5th or 6th time, the hard stools become regular stools and they become diarrheal stools. We see a lot of pain with IBS. And so, your patients who are like, I'm always constipated. And then you ask them, do you have pain? And they say, no, I'm not I'm uncomfortable. I wouldn't say I'm pain. Well, then it's probably not IBS. We often hear complaints of bloating, which, the definition of bloating from my perspective is a subjective discomfort with normal amounts of gas or stool. But often when your patients say that they're bloated, they might also mean that they visibly look distended. That's not necessarily an IBS symptom, but certainly that is something that often co-occurs with the subjective feeling of fullness or discomfort. Stress can make IBS symptoms worse, but stress is not the cause of IBS, and relaxing and going on vacation or doing yoga does not cure or treat IBS. And people with IBS will often report a variety of common food triggers. Again, anything that will stimulate a nerve ending in the bowel can potentially be a food trigger in IBS, because people with IBS have visceral hypersensitivity. So when a nerve is stimulated, a nerve will be overstimulated very often. If someone is waking up overnight with diarrhea, it may not really be IBS. Typically, we don't see nocturnal symptoms. So as I mentioned earlier, a lot of ways that IBS can be treated. On the constipation side, we have the osmotic laxatives that work by drawing excess water into the bowel and kind of softening stools and, scooching them along. Those are things like magnesium or Miralax would be considered osmotics. Stimulant laxatives, so those are things that actually stimulate bowel contraction. So those are things like Adulcolax or Acena. Stool softeners, ish. Secretagogues. So these are the category of medications that actually increase bowel secretions through different channels in the colon. So these are things like Amitiza and Linzess and Trulance. Those are secretagogues. Vibrant is a medical device. It's like a pill, like a little vibrating pill that patients will take, I think, twice a day. And it just creates these vibrations that cause waves of motility. And we have SSRIs, and we have what I call rectal RX, which are things that you stick up your bum. So these are things like glycerin suppositories or enemas. On the diarrhea side, we use antispasmodics to kind of help treat some of the pain and that frequency of running back and forth or racing to the bathroom after a meal. Antidiarrheals, whether over the counter or prescription. We have serotonin receptor agonists, which treat both diarrhea as well as pain. Tricyclic antidepressants, again, which can treat both diarrhea and pain. And then whether you have D or C predominant IBS, there's, potentially a role for fiber supplementation, although the types of fiber may vary depending on what you're treating. Peppermint oil for abdominal pain, SNRIs, cognitive behavioral therapy or gut-directed hypnotherapy, again, to deal with some of the pain and how the brain is involved in all of this in terms of anticipating potential trigger situations and then those becoming a self-fulfilling prophecy, or the brain's role in just over-perceiving pain. So that's kind of IBS in a quick little nutshell. Let's scooch now over to SIBO and talk about what that is and how it's treated. SIBO stands, as I think we should all know, for small intestinal bacterial overgrowth. This is excess bacteria living in the wrong neighborhood. They may be pathogenic bacteria. They may not be pathogenic bacteria. Some SIBO is actually some oral, like normal oral flora that is taking up shop in the small bowel. Some SIBO is normal colonic flora, commensal organisms that are taking up shop, again, in the wrong neighborhood. There is a sort of an offshoot of SIBO that is, being called EMO, and it's kind of now being treated as a separate clinical entity. EMO is intestinal methane overgrowth. And that is the overgrowth of organisms that produce methane gas. These are not actually bacteria. They are archaea, which is a different category of microorganism. And they produce methane gas, which we are starting to understand is extremely constipating. And whether you're overgrowing it in the small bowel or the colon, it's still considered, at a certain level being excessive and problematic. And so EMO would refer to a clinical entity where there's too much methane overgrowth anywhere in the intestine, small or large intestine. These are conditions that typically onset due to a guardrail failing. In other words, your body has a lot of guardrails in place between gastric acid and the ileocecal valve, to and pancreatic secretions, which have antimicrobial impacts. Lots of things our body has in place to make sure that the small intestine is not particularly hospitable to bacteria. When a guardrail fails, that is really where conditions can become ripe for excess bacteria to overtake the small intestine. In that regard, you can think of SIBO and to a certain extent also EMO as sort of like a canary in the coal mine scenario, which is, okay, this is definitely a clinical problem and something that needs to be treated, but it is often reflective of something else having gone wrong. And what is that thing? Sometimes it's just a medication side effect, like a PPI. Sometimes it's an indication of a very high stool burden. But sometimes it's an indication of celiac disease or, Crohn's ileitis, or pancreatic insufficiency or something in the system or something systemic, that has made that small bowel hospitable in a way that it shouldn't be. And which kind of dovetails to the next statement I'm going to make, which is we know how to treat SIBO. Most SIBO is treatable, sometimes not in the first try, but on the second or the third. But unless you kind of really figure out why a patient developed it, there's a really high chance they're going to get it again. Because why wouldn't it? If there's conditions ripe in the small intestine for bacteria to overgrow and you don't address those conditions, if it's possible to address them, there's a good chance it will come back. And that's why you see on the internet, and I think, frankly, even in the clinical community, sort of SIBO has developed a reputation as being a chronic condition or a recurrent condition or something, why bother treating it? It's just going to come back, or, and not a whole lot of attention into prevention. This is just a little bit of background. So to understand sort of what normal levels of bacteria are, as you can see, kind of as you move from the proximal GI tract to the distal GI tract, the concentration of bacteria per milliliter of secretions or stool starts to increase exponentially, starting with almost none, like basically sterile in the stomach. And as you move along to the duodenum, the jejunum, the ileum, and the colon, you start to see greater and greater concentrations. And so clinically, SIBO is defined as having more than 10 to the third, which is 1,000 bacteria per milliliter of secretions. In the proximal jejunum. And yes, you can diagnose SIBO this way. Sometimes the physicians in my practice will. If they're doing an endoscopy anyway and they have a patient who doesn't respond to any antibiotics that they're giving them, they might actually take a sample of jejunal, or I guess, proximal jejunal secretions, and send it to a lab and culture it and see what the patient is actually growing and then choose an antibiotic for it. So it's not commonly done, but it can be done. Some of the common organisms implicated in SIBO are Enterococcus, various species of E. coli, and Klebsiella. What's interesting about Klebsiella is it happens to be a really prolific histamine producer. And then as far as methane producers, there's only one. It's called Methanobrevibacter smithii. And that is the archaea that makes methane. So how do we diagnose SIBO? Across the board, it's pretty much done by breath testing. It's not common for the jejunal secretions to be taken. This is a patient comes in, they're fasted, and we are measuring their exhaled gases after we have given them something to drink that is very fermentable by bacteria. We typically measure hydrogen and methane. Why? Because these gases are not produced by human cells. These gases are only produced by microorganisms. So if they are on the breath, we know that a microorganism made them and a human cell did not. And so when we see various types of these gases on the breath, we can ascertain that they were made by bacterial or archaea fermentation. There is a breath test out there called TrioSmart that also measures hydrogen sulfide. It hasn't been widely adopted as far as I can tell yet. I think it's a little bit trickier because hydrogen sulfide is a gas that is made by human cells as well. And so it may be a little bit trickier to really understand what those numbers mean as far as when we see them higher or lower, like, does that mean that a human cell made them? Does it necessarily mean that a bacteria made them? Are we comfortable that the normal levels of hydrogen sulfide have been well validated and vetted? So I think that that one has taken a little bit longer to really be adopted widespread. For SIBO, you are drinking a fermentable substrate. It's either glucose or lactulose. There are pros and cons to both of those substrates, but that is what's used. Patients leave us some samples, and then we see, if breath gases start to increase at any point during the test. And where they increase during the test tells us where the fermentation took place. If it happens really early in the test, then, it's probably happening in the small intestine. If it happens late in the test, it's happening in the colon. This slide pretty much just summarizes what I just said. We use the timing of when we see those gases show up on a patient's breath to estimate or approximate where the fermentation happened, with the understanding that we are making assumptions about oral cecal transit time that may or may not be accurate for any given patient. That's the trick with breath testing. When you hear a doctor say, oh, breath testing is not reliable, I don't trust breath testing, one of the big assumptions that breath testing makes, which is, one of the sources of its potential vulnerability, is it does assume a normal oral cecal transit time. We are assuming that when someone is fasted, and we give them a liquid to drink, that liquid, should clear the, should basically get to the colon, clear both the stomach and the small intestine between 120 and 180 minutes. That may or may not be true for the patient sitting in front of you. If their oral cecal transit time is really, really fast, or if it's really, really slow, we may misinterpret breath test results. And that is one of the downsides of this test, is that it assumes a normal oral cecal transit time. In order to try to kind of cover for that, or to buffer that possibility, we use pretty strict cutoffs for interpreting test results as positive. In other words, we are very conservative with what we are calling for sure. We believe that this is happening in the small bowel, and that cutoff is 90 minutes. In other words, it is possible that at 120 minutes, breath gases that show up may still originate in the small intestine, but for the purpose of breath testing, we give it a 30-minute buffer and we say, well, it could be 120, but we're going to cut it off at 90. And anything after 90 is not necessarily small intestine. So, the current consensus-based criteria for a positive SIBO test is we need to see a change in the breath gases in the first 90 minutes to call it a positive test. But there are still false positives and negatives if somebody does not have a normal oral cecal transit time. If someone is super duper slow and we see some gases go up at 150 minutes, we would assume that that's the colon. But if someone has gastroparesis, that could be their small intestine, right? So you wouldn't necessarily want to use this test if you knew that somebody had gastroparesis. So how do we look at a breath test, and what is the current criteria for a positive test? Basically, you're looking at an increase in breath gases over baseline within those first 90 minutes. For hydrogen, you're looking at a 20 part per million rise over baseline. For methane overgrowth, you just need to see that number being 10 parts per million anywhere during the test to be considered positive for EMO. And this is a newer criterion. It used to be we would still need to see a rise in breath gases in the first 90. They changed that. So now if you see 10 or more anywhere in the anywhere in the test, small or large intestine, that would be considered positive for EMO. So in this particular test, you can see the patient's baseline was 4 parts per million of hydrogen. And somewhere between 75 and 90, it got to 24 and beyond, right? So this is a positive test for a hydrogen predominant SIBO. I was going to say something about that and then I forgot. Oh, right, baseline. So the most important thing not the most, but a very important thing here is you need a good baseline reading. If somebody messes up the baseline sample, and sometimes when people will do an at-home test kit, they will forget, like, they're confused and they're stressed and they're nervous about the test, and they will drink the substrate before they give you a baseline reading. If they've done that, they might as well not even do the test. Because if you don't have a fasted baseline reading, you have nothing to compare it to. And so it's really, really important to get a fasted, clean baseline and then, measure any rise off of that number. Historically, people have used an elevated baseline. So if a baseline was like 20, they would say, oh, you have SIBO, and not even finish the test. Or they'd finish the test, but it wouldn't even matter what the numbers would say because the baseline was elevated. That is not a that is not a standard way to interpret a SIBO test. That is not a consensus-based interpretation of test results. An elevated baseline gases doesn't necessarily mean SIBO. Often it actually means that the patient has a high stool burden, or maybe it means that they have gastroparesis and we're actually seeing some of last night's dinner still in the stomach now working its way through the small intestine. Maybe it means like dentures, like a lot of just hydrogen on the breath from, oral bacteria. If someone has, poor oral hygiene or dental health issues. And so you cannot assume that an elevated baseline means that someone has SIBO. You need to use the consensus-based interpretation. As far as treating SIBO, antibiotics are the only evidence-based treatment for SIBO or for intestinal methanogen overgrowth. We commonly see rifaximin plus or minus neomycin prescribed, but they're not the only options. And if you look, it's free, available, full text online, the 2020 ACG clinical guidelines for SIBO. And if you look at table 5, you will see a list of a bunch of different antibiotics and what dose and frequency and what the efficacy rate is based on available research for treating SIBO. And I think that this is important because sometimes patients will say, well, I tested positive for SIBO and then the doctor gave me Xifaxan and it didn't work, and they gave me more Xifaxan and it didn't work. And then they gave me a third round of Xifaxan and it still didn't work. And then they just said, well, I can't treat you. You just, need to be on a low FODMAP diet. And I encourage my patients to share these clinical guidelines with their doctor and maybe discuss whether they might be a candidate for something other than Xifaxan. Because Xifaxan does not have a 100% resolution rate for SIBO, right? We don't know what exactly you're overgrowing, and therefore, if it doesn't respond to Xifaxan, maybe a doctor could offer you something else. As I mentioned earlier, we see that recurrence rates can be quite high because we rarely see patients getting much of an evaluation to figure out why they got SIBO. I want to spend a moment on herbal remedies. I think especially for us as dietitians, this has become extremely popular. Whether you're a functional dietitian or a non-functional dietitian, there's all sorts of herbal protocols and the Johns Hopkins protocol and, these like very extensive things of like oregano oil and then, all these herbals and then probiotics and blah, blah, blah. And I think it's important for us to understand that there is no evidence basis for these at all. All of the herbal remedy things originated from this one study in 2014. And if you read that title and nothing else, of course you would think that herbal therapy is evidence-based. That title says so. However, if you actually read the study, and I think it's so important for us who care about evidence-based practice to read the study, this study does not support the title of the study. The findings do not support the title. This was a retrospective chart review. It was not an intervention study. They looked back, it's 11 years old at this point. They looked back at 100 and something people's charts. How did they define whether or not a patient had SIBO? They used a very non-standard criteria. They used an elevated baseline of hydrogen as saying that someone had SIBO. If you think about that, someone with an elevated baseline, the most likely cause for that is that they're full of stool or constipated. Then you can almost understand why giving somebody some herbals that maybe had a laxative effect might clear their SIBO because it cleared the baseline because maybe the baseline was actually stool burden, right? So like we're not using a good criteria to define SIBO. So we don't even know how many of these people truly had SIBO by commonly accepted criteria. And then when you look at the analysis of the herbal treatments that were compared to rifaximin that say that they were equivalent, these were not statistically significant. In other words, they were not actually equivalent because there was no statistical significance to the findings. And the dose of rifaximin that were used in this particular study in 2014, it was 400 milligrams twice a day. The standard treatment of rifaximin for SIBO is 550 milligrams 3 times a day. So they're saying that herbals were comparable to a low dose of rifaximin or a subtherapeutic dose of rifaximin, but they weren't even. And then lastly, the herbal therapies that were used in the study were not standardized, right? This wasn't an intervention study where they gave a group a specific herbal and they gave a different group the rifaximin and they compared them. These were people who got random different herbal therapies from different providers, and this was a chart review. So it wasn't even that these patients all got the same herbal. So like this is like a really, really, really weak basis for a whole what I think is really a cottage industry of herbal treatment for SIBO. Um, and our patients are spending a ton of money on these. And we don't have all that much confidence or really any that these expensive herbal remedies are going to help a patient. And so I think it's important for us to be honest. If a patient wants to try herbals, look, I don't think it's going to hurt someone, but they need to be aware that it's really hit or miss. There's no evidence to support it. It could be very expensive, and insurance isn't going to cover it. And to be honest, and set expectations accordingly. Getting off my soapbox, back to SIBO. What causes SIBO? We mentioned that SIBO is something, a guardrail having failed. There are many, many, many reasons why someone could get SIBO. Just yesterday, I saw someone who got it right after a really nasty food poisoning episode and from a trip in Mexico. That's not something that is likely to recur for her. She's never had SIBO before. She got food poisoning, which is a really common reason that people get SIBO. You treat the SIBO, there's a pretty good chance it's not going to come back for someone like her. If you talk about somebody who's had a Roux-en-Y gastric bypass and they have a blind loop of duodenum, or maybe someone with Crohn's disease who has had a resection, they lost the ileocecal valve, they now have an anatomical fault where bacteria can kind of flow really freely in and out of the small intestine, or there's stasis of bacteria in that blind loop. Like they will probably get SIBO repeatedly, and there's nothing really, not a whole lot you can do about it. Um, Similarly, someone who has like atrophic or autoimmune gastritis that is hypochlorhydric, they just don't have a lot of stomach acid. And, we see that with PPIs, there's actually a pretty significant risk for SIBO, even with some pretty short-term use of PPI medications. H. pylori can cause a hypochlorhydria, which is why we often see SIBO as well. Motility disorders, right? If the small bowel is really slow, if someone has scar tissue or adhesions, or any kind of motility impairments due to endometriosis, like anything that kind of impedes motility in the small bowel can cause SIBO. Pancreatic insufficiency, because pancreatic bicarbonate has an antimicrobial effect. And when you don't have pancreatic bicarb, you lose that antimicrobial effect in the duodenum. Um, Crohn's ileitis. I mean, lots of things. And so there's a lot of reasons why someone could get SIBO. And if they got it once or they keep getting it over and over again, ideally the doctor and the patient would want to really discuss, could any of these things be at play, and or any of these things can be addressed. Okay, so here are things that I hear all the time. I hear from doctors and from patients online that SIBO is a chronic condition, that like the people call themselves SIBO patients, or I have SIBO, as if it's like an identity, like it's, almost like you're a redhead or something. Once you have SIBO, you can never get rid of it. I hear people saying that, oh, SIBO is all bad bacteria, so you need to take good bacteria like probiotics to balance it out. We hear all about the herbals, the natural antimicrobials, again, that are not evidence-based, but also somehow thinking that if something were to be able to kill a bacteria in the small intestine, that it wouldn't also kill bacteria in the colon. Like we don't have any herbals or prescription antibiotics that can just narrowly target SIBO and leave everyone else alone, because SIBO bacteria are the same bacteria that live elsewhere in the body. We're hearing things around elemental diets and this idea that you need to starve and weaken the bacteria to make treatment more effective, or do the same thing with a low FODMAP diet. But then I've also heard doctors tell patients, no, 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 you need to load up on FODMAPs and draw out the bacteria and make them super active so the antibiotics will work better. Literally the exact opposite argument. And the fact of the matter is, we don't have evidence for any one of these things. Nobody has studied whether diet will treat SIBO, except for the elemental diet. We have a tiny bit of research on that, which I'll talk about later. Nobody has studied whether a FODMAP diet can help, prevent SIBO from coming back. Nobody has proven or demonstrated that eating FODMAPs will cause SIBO to come back. Nobody has shown any good evidence to talk about probiotics, and I have a slide on that later. So all of this stuff that's circulating online that we're hearing as providers and our patients are hearing, it's all hypothesis. It is possible that one of these things on the slide is true. it is possible that one or more of them are false. But we have no good evidence to answer these questions. And again, I think it's important for us to be honest brokers in terms of how we talk about SIBO with our patients. Okay, so again, coming off my soapbox, we're going to shift to the second half of this talk, which is differentiating between IBS and SIBO. They're hard to differentiate. First of all, they often overlap. And so someone who has IBS has a 3.7 times higher likelihood of having SIBO compared to a healthy individual. That's a really big risk premium. And so in this one particular meta-analysis, we saw that prevalence of SIBO and IBS was about a third just in this one snapshot analysis. Like, that's a lot. So we often see these conditions overlap, which, is tricky because then somebody who has IBS and then they have like an exacerbation, which may turn out to be SIBO, their doctor is just dismissing it as an IBS flare, right? When really, no, it's SIBO and it could be a lot better with antibiotics. Or if somebody comes and they, have SIBO symptoms and then the doctor's like, whoa, sounds like IBS, try some fiber or, take an antispasmodic. Because the symptoms are really similar. And like I said, they do co-occur. I think as a clinician, if you're trying to like probe to kind of understand whether, it seems more like one or the other, especially with diarrhea predominant IBS, generally speaking, it looks really different from SIBO as far as how the morning goes. So someone with IBS-D, their morning is their worst time of day. That's when their bowels are most active between waking up and 10 a.m. And then they're often pretty stable after 10, 11 a.m. SIBO is the opposite. People typically feel best in the morning because they're fasted. They haven't eaten anything in hours and hours and hours. So their morning is actually their best time of day. So that's one potential differentiator. Also the time of when they start to experience gas and bloating relative to a trigger food, mostly FODMAPs. So a lot of people with IBS experience gas and bloating if they eat like beans or other high FODMAP foods or broccoli or Brussels sprouts or whatever. But it's usually going to be 2 to 6 hours later because the gas doesn't really hit until it gets to their colon, which can take several hours after eating. With SIBO, we typically see the gas and bloating onset within 30 to 60 minutes, very quickly, right? Because the gas is happening in the small intestine. I like to also think about the salad litmus test, which is, most salads are pretty low FODMAP. And so many people with SIBO actually find that salads sit pretty well. Someone with a diarrhea predominant IBS typically does not find salads to sit very well. And so it's not like a hard and fast rule, but that's something that I like to probe around. IBS generally doesn't cause weight loss, but SIBO can. IBS really should not induce any vitamin deficiencies, but SIBO often induces specifically a B12 deficiency. And so these are just some things that you might want to be paying attention to see if you can kind of feel out when IBS is more than just IBS. And then the last piece of this talk, which for us, the most important, is diet. How do we manage these patients nutritionally? This is a new slide, Jocelyn. I just threw this one in because it's fun. When you think about diets for IBS, think of it as sort of like what we know, what we have now that is evidence-based clinical practice. But I also just wanted to tee up some of the interesting stuff that's under investigation and stuff that's on the horizon that's still like a little bit more theoretical, hypothetical, but that's being investigated just so we can all kind of know maybe where our job is going in the next 5, 10 years and the other diets that we might be using in these patient populations in the future. And so we will go through in detail the evidence-based ones momentarily. But some of the things that are under investigation now, I think one or two studies on I think 2 studies at least on the Mediterranean diet and whether that's helpful for IBS. I think the jury is still out. The trick with the Mediterranean diet is, it can be pretty high in FODMAPs and specifically polyols can bother a lot of patients. And so, does the Mediterranean diet perform as well as the low FODMAP diet? So far, no, but is it better than a standard diet? Maybe yes. The low nickel diet, there's been a couple of studies on patients with IBS who have tested positive for nickel allergy. In other words, we already know that they have a nickel allergy. They're sensitized to nickel. Whether a low nickel diet helps manage IBS symptoms or persistent IBS symptoms in those patients, as well as in patients who have celiac disease who have persistent IBS symptoms, even though their celiac disease is quiet. And so the research is just very new, it's nascent, but I think this is kind of an interesting angle, and I have a very strong suspicion that we will be using the low nickel diet in some of these patients who have nickel allergies. I've used it, and when it works for the right patient. And so I think that this is probably one that we're going to have in our toolkit for IBS patients with nickel allergy. I think I can envision us using this one soon. And then the low histamine diet, I have a question mark around there. Nobody, to my knowledge, has studied the low histamine diet yet. However, histamine is being studied as, a purveyor of IBS symptoms. Right now, a lot of the investigations are more focused on using medications to suppress histamine, like antihistamines and mast cell stabilizers, to manage IBS symptoms. But the idea that we are exploring the role of histamine in IBS symptoms does beg the question as to whether at some point we will be looking and investigating the low histamine diet as well. I'm not sure if that's going to really pan out too much. It's not clear that dietary histamine is the major source of histamine in the gut so much as sort of our own endogenous production, but we'll see. And then I think further on the horizon, looking at sort of exclusion diets that are more personalized, that are being guided by novel diagnostics. And this is sort of more in the camp of, are some IBS symptoms more immune system mediated? Sort of like atypical food allergy reactions that are happening locally in the gut. And there's a couple of modalities that are being investigated. One is called CLE, which stands for confocal laser endomicroscopy, which is basically like a microscope, like your endoscope with a microscope on the end of it, where doctors can look during real time, during an endoscopy, be looking at the tissue of your bowel during endoscopy under a microscope. And they kind of inject you with some contrast fluid, and then they kind of put little allergen samples on the gut and watch in real time whether there is cellular changes and cellular damage happening. That is experimental-ish. I think it's kind of been rolled out in a couple of pediatric clinics in the country. It's a little bit in Germany right now. It's extremely expensive and insurance isn't covering it. So I think that we're not really going to see a tremendous rollout until the economics are worked out. But, these are exclusion diets that would be based on these these really interesting novel investigations happening in real time. And there was one sort of pilot-ish study. There's about 100 people where researchers developed an IBS-specific IgG panel. In other words, they're looking at IgG antibodies, and the panel that they developed was not just some standard, commercial direct-to-consumer, boil the ocean, 50 different IgGs, but they chose a panel based on foods where a group of IBS patients had much higher IgG levels to those foods compared to a control group of healthy people. In other words, these are foods that they thought maybe an IBS patient could be a little bit more sensitized to. And they chose a panel based on that, and to see whether, if you did IgG level testing on a population and did an elimination diet based on that, whether it would improve IBS symptoms. And so again, it was one study, it was 100 people. The results were like interesting, like not nothing, but also not a slam dunk. So I think it's an area that's going to be explored more. It may turn out to be nothing. It may turn out to be a really great way to help guide our patients. It's on the horizon. But going back now to what we know is evidence-based. The three kind of standard diets that we use in clinical practice that you can kind of layer them together is the NICE diet guidelines, which are basically like, don't stay away from spicy things and coffee and polyols, which, have an osmotic laxative effect, and, eat smaller amounts and not big meals, and, eat softer, mushier foods and not like big rough-and-g salads and kale. That's basically the NICE diet guidelines. A version of that we use in our practice a lot is what I call the GI gentle diet, which again is kind of focused more on like meal size, meal texture, the type of fiber that we give our patients. So staying away from sort of rough-and-g salady, intact coarse fiber and sticking to soluble fiber. And these are for patients that really are not great candidates for a low FODMAP diet, or maybe who tried a low FODMAP diet and they didn't respond to it. And so, the GI gentle diet, I also use it a lot in my constipated patients, more so than low FODMAP, because this, I think, tends to work a little bit better for someone who's very, very backed up. And then, of course, we all know we have the low FODMAP diet or versions of that, a FODMAP gentle diet, and these can be layered and mixed and matched, but this is kind of the triumvirate, if you will, of the evidence-based dietary approaches for IBS symptom management. As far as soluble fiber therapy, as I like to call it, this is really focused on changing the type of fiber that is predominant in a patient's diet. Someone who has diarrhea predominant IBS, you might want to give them more soluble fiber to kind of slow things down and form and consolidate their stools, and limit the insoluble fiber, which is really bulky and it speeds up their transit time, and maybe that's not going to feel so awesome. And so, kind of manipulating the ratio of those two fibers can be really helpful to manage diarrhea and bowel urgency. But also in someone who has a constipation, they're super, super full of stool, adding lots of roughagey, bulky fiber that takes up so much space also just might create a lot of pain and bloating. And so we might also do a version of this diet, or fiber manipulation as well for someone who's constipated. And if they do want to have, greens and nuts and things like that, then maybe like we puree them and just kind of take the bulk out of it. So the fiber modification can be really, really helpful for IBS symptom management. And that's sort of a combo of GI gentle and soluble fiber therapy. Moving into low FODMAP, I think that we're all really familiar with this diet. I don't need to really define it for you all, but again, this helps specifically with management of diarrhea when we avoid those osmotic FODMAPs like lactose, fructose, and polyols, but also with gas and bloating, especially when we avoid the oligosaccharides and the fructans and the galacto-oligosaccharides. It's very helpful often in patients who have SIBO, but not always. Generally speaking, if you are thinking of like what are the most universally GI friendly forms of healthy foods or fiber foods, it's foods that are both soluble fiber predominant as well as low FODMAP, right? Because they're not creating gas, they're not creating diarrhea, they're not super bulky and painful. And so it's the foods that I have circled here in red are kind of like the most universally tolerated foods: cantaloupe, carrots, green beans, zucchini, clementines, papayas, etc. Oatmeal. As far as managing individual FODMAP intolerances, to the extent that you can identify them, just a list of foods that are high in lactose and certainly using lactase to cover them if a patient doesn't want to avoid them. Same for fructose, avoiding foods that are high in excess fructose or using over-the-counter enzymes like xylose isomerase with the meal to help improve digestion of these. These are all available. Multiple brands sell them. They're all available online. Polyols are a little trickier. There's a lot of different foods that have different polyols. Not everybody reacts to all the polyols. So someone might really have a problem with mannitol, but be okay with sorbitol. So it's kind of good to probe. A lot of my patients actually do okay with avocado, but like, woo, cauliflower and mushrooms kill them, right? So, just understanding which foods have which polyol can be really helpful in limiting the amount of restriction that a patient needs to follow, especially because we do not yet have enzymes to help convert polyols into something more digestible or, yeah. So until we do, understanding a specific polyol intolerance can be important in these patients. And then we do have a small but non-trivial number of tools. And honestly, like people ask me, like, do you use a lot of supplements? I think the supplements on this slide are 90% of the supplements that I recommend in my practice. There's not much beyond this. There's a couple for upper GI issues that I'll use for GERD and gastritis and things like that. But this is maybe 85% of what I recommend is on this slide, which is to say, yes, for the right patient, a well-chosen supplement can be incredible, but you don't need a whole lot of different things in your toolkit to manage most IBS and SIBO symptoms. We can use magnesium oxide or hydroxide as an osmotic laxative. We can use senna as a stimulant laxative, generic forms, brand names. We can use enteric-coated peppermint oil for abdominal pain and crampiness and urgency. We can use various forms of soluble fiber to firm up an IBS-D kind of scenario and consolidate those multiple trips to the bathroom. We can use bulking fibers like psyllium and calcium polycarbophyll to help either with constipation or those crazy swings, the pendulum between diarrhea and constipation. I also like to use those for people who have had bowel resections to just create some form and make the stools easier to hold. And then for various carbohydrate intolerances, whether they are primary, whether they're secondary to SIBO, a whole constellation of enzymes, whether individual enzymes or, enzyme cocktails. Obviously, Fadzyme is one of them. Patients will often ask, and other providers will say, like, oh, do you recommend enzymes? And I'm like, well, it depends which enzyme for what, right? I mean, a lot of the, digestive enzymes that our patients are encountering in the store or online have like, 10 to 15 minuscule doses of different enzymes, most of which are not at all relevant to what this patient is maldigesting. And then therefore the levels of the relevant enzymes, whether it's like the alpha galactosidase or the lactase or whatever, the doses are subtherapeutic because the pill has to fit so many irrelevant things in it that the relevant things are just at subtherapeutic doses. So my personal philosophy is figure out what is the patient actually reacting to, and then find a supplement that has therapeutic doses of that one or few things, rather than just give them a bunch of random stuff like throwing spaghetti against the wall and maybe it'll help, maybe it helps a little, but not enough, because again, the doses are of what you actually need are just subtherapeutic. As far as diet for SIBO goes, switching from the IBS diets to the SIBO diets, no, surprisingly, nobody studied it. So all of the data we have on low FODMAP is really for patients with IBS. I haven't seen any studies for whether, any of these diets are superior to others in SIBO specifically, with the exception of the elemental diet. There was one study, 10 something years ago, that showed a potential benefit of the elemental diet. And now there's a company, there's a product that Cedars-Sinai Hospital in California has developed, an elemental diet called Mbiota, and they have their own clinical studies like for their product that they say are showing efficacy. But that's really the only research we have on elemental. All the other diets really haven't been studied. And I will say that anecdotally, most patients who have SIBO will respond to low FODMAP, but not always. Sometimes patients respond much better to just a low carb diet. And they can eat Brussels sprouts or cauliflower, but they can't eat a banana or rice or sugar. I've had some patients who just can't eat fruit. Like it seems like fructose for them is a real big problem, but they can eat other things and not be symptomatic. And then I have some patients with SIBO who feel horrible with fat. Whereas in others do great on like a keto diet that's high in fat but doesn't have carbs. And so while it's been my experience that the diet that helps the most patients with SIBO is low FODMAP, it is not a given that that is the SIBO diet. And you really need to listen to your patient and listen to what they tell you happens, what they feel their safe foods are, what they feel their trigger foods are. And don't assume that we should always be defaulting to a low FODMAP diet. Maybe carbs are an issue. Maybe, like I said, fat is an issue. Maybe fructose is an issue. And so you want to be as minimally restrictive as possible and not dogmatic. You want to really, not textbook, not cookie cutter, not dogmatic, listen to your patient. We also just need to be realistic with our patients, especially because they're not getting this message online. And frankly, they're not even getting the message from their doctors that we have no evidence that diet will cure their SIBO. And we have no evidence that staying on a low FODMAP diet for a month or 6 weeks or 4 months or 6 months or whatever after they've been treated for SIBO is going to improve their chances at preventing recurrence. Nobody has studied this. That is just a guess. It is just somebody's guess. And it's important for us to understand because patients will often get stuck on a restrictive diet for a really, really long time. And the longer they're on a restrictive diet, the greater the chances are that they are going to develop ARFID, which I think is a huge unintended consequence of, frankly, the low FODMAP diet and some of these other diets as well. Patients become very, very fearful of liberalizing their diet the longer they've been on them. Okay. I'm going to spend a minute on probiotics because, again, this is another sort of hot topic and a very debated topic. And I think that there is a lot of recommendations going on in the clinical world from both physicians as well as dietitians that probiotics somehow should be part of the SIBO treatment protocol or a SIBO prevention protocol or a post-antibiotic, repair, heal the gut, rebalance the microbiome kind of scenario. And I think it's really important for us to know is there is no good evidence on whether probiotics are helpful or harmful. There is no evidence that they prevent SIBO. Let's start there. There's just none. There have been 7 studies to varying degrees that have been examining the question or adjacent questions of whether probiotics help to treat SIBO. And there's a 2018 meta-analysis that, again, had a very optimistic title that, basically claims that probiotics have a very high SIBO decontamination rate or treatment rate. But if you actually look at every single study in this meta-analysis, which I did, it is appalling. It's really appalling. There were 7 studies that looked at probiotics alone, and 2 that looked at probiotics with antibiotics, which, if you're asking, well, how do you know whether the probiotics decontaminated the SIBO or the antibiotics did? That would be the right question to ask. You don't. A study where you're also getting antibiotics tells you absolutely nothing. And so, we're really just looking at whether any of the 7 probiotics alone studies can indicate to us whether probiotics can actually treat SIBO. In the 7 studies, only one of them actually tested the patients after a probiotic intervention to prove it was eradicated and had statistical significance. And this was a study of 53 people with cirrhosis, chronic end-stage liver disease. All the others were studies that were not statistically significant. One was in kids, a couple were in healthy adults, another one was also in liver disease patients. Most of them did not actually retest for SIBO. They did it just based on how patients felt. This is not good science, people. This is not good science. And why does it concern me that we are potentially telling patients, well, we don't have good evidence, that maybe it'll help treat SIBO, but it makes sense because you're taking antibiotics and maybe we should take probiotics, and, SIBO is a dysbiosis and maybe probiotics can help with that. So we can't be hurting someone, can we? Yes, we can be. There is research coming out now, very recent. I saw it presented at DDW 2 years ago and again last year, where at least 2 different labs in this country in the country have been studying what giving probiotics in a post-antibiotic state does to the gene reservoir of antibiotic resistant genes, which we call the resistome. And what they are finding is that after taking antibiotics, when you give somebody probiotic supplements, it seems to increase the abundance, the reservoir of antibiotic resistant genes. And that makes sense if you think about it. If you just took a course of antibiotics, what's left in your gut? Who is left in your gut? Who's left are the bacteria who have genes that are resistant to the antibiotic that was just administered. And so why does giving probiotics seem to increase their replication? Because other studies previously from 2018 that have been published in the journal Cell have demonstrated that when you take probiotics after antibiotic, it actually delays your gut microbiome's restoration back to its own baseline. It takes longer to get back to your own baseline when you take a probiotic supplement after an antibiotic. Why? Because probiotics are interloper species. They're not part of your native flora. And so when you're taking sort of this outside species, it is occupying an ecological niche that used to belong to your own microbiome. And so now you have this delay of that beautiful balance that, helps kind of crowd out pathogenic species and antibiotic resistant things. You are delaying restoration of balance by supplementing a probiotic. And in so doing, you may indeed be increasing the reservoir of antibiotic resistant genes. And by the way, this is not limited to SIBO. This is after an ear infection or a sinus infection. The whole world is talking about the common knowledge and the common sense of taking probiotics after antibiotics, and it just makes sense to do to, heal the gut and repair the damage and repopulate the gut with good guys. And what if that is so, so harmfully wrong? What if that is really bad advice? And so, in the spirit of doing no harm, maybe let's be conservative with our recommendations. Maybe let's be evidence-based and make sure that if we're going to recommend probiotics to somebody, especially after antibiotics, especially after SIBO, that we actually have really solid evidence that this is a good thing, that it's a beneficial thing, because it may not be. It may be a harmful thing. So in our practice, we don't do it. We avoid bacterial probiotics for people who have SIBO or suspected SIBO or SIBO risk factors. We also don't want the bacteria pills to give them SIBO. And if somebody has, antibiotic associated diarrhea, or they have a history of C. diff, for which maybe a Florastora, which is Saccharomyces boulardii, is an evidence-based thing, we will do case-by-case exceptions for those patients for that particular probiotic. But in general, we're really, really conservative with it. And I encourage all of us to really examine our practices with regard to SIBO and IBS and supplements and make sure that we feel really solid on the science and the evidence. Okay. So in conclusion, IBS is a positive clinical diagnosis. SIBO can be diagnosed with breath testing. They can present similarly, but they are treated and managed differently. Be thoughtful, be cautious when you're considering interventions that do not have a strong evidence basis. Make sure that we are not doing any harm. And understanding that our role as dietitians and the role of diet is for symptom management. We cannot yet cure or prevent any of these conditions with diet. Sorry, I went over, Jocelyn. That happens with me sometimes.
That was incredible. Thank you. No, we're not over just yet. I think we have some time for a couple questions. We do have so many amazing ones in our chat here. I'm also just seeing some questions around kind of logistical things. For anyone looking for slides, we're not sharing the slides, but we will be sharing a recording to this webinar in the next 24 hours, let's say tonight or tomorrow. You'll be able to kind of review it, and for any clarifying questions, that's hopefully where you can get answers to those. But for our questions here on some of these topics that you covered, Reem here has a first question asking about what patients who might benefit from an antihistamine diet, and then a follow-up here. If so, the antihistamine diet varies greatly, so can you suggest which one to follow?
So the low histamine diet has not been studied in IBS. So it is not, I would not say that it is part of my usual IBS protocol. And you are right that there are a lot of versions of it online. I mean, I have my own version of it that I had a lot of grad students deep dive into primary research. I think Janice Joneja, I don't know how to pronounce her name. She's a dietitian PhD who I think is a pretty reliable source for info on the low histamine diet. I generally will use that diet for patients who I think are having histamine-mediated symptoms that include GI symptoms, but may not be limited to GI symptoms that seem to correlate to high histamine foods, but it's not like a standard IBS diet that I use.
Thank you. Great. Here from Nancy, we also had a couple other questions around Senna and frequency. This one is, how do you recommend Senna, i.e. for how long, optimal dose? Please comment on its safety.
So both the ACG, the American College of Gastroenterology, as well as the AGA, the American Gastroenterological Association, issued a joint guidelines document on managing chronic constipation. And this is the first time they have recommended both Senna and magnesium as first-line treatments for chronic constipation. So Senna is regarded as safe enough by the two major GI agencies as a first-line treatment. So it is safe for long-term use. There's no good evidence of harm or, this idea of cathartic colon, that has been disproven. And so I recommend Senna. A standard dose is 1 to 2 pills. Doctors will sometimes go higher. I usually don't. I think it works better for people who have a very, very high stool burden. They're really, really full of stool. I think Senna works better than an osmotic. Potential side effects are cramping. But if patients are finding that they have a hard time with osmotics because Miralax and magnesium just make the stool too mushy and draws too much water in, and they can't get the dose right, it's either nothing or mush, Senna often works better. And I don't, and it's safe for long-term use.
Here from Donna asks, I've heard some RDs talk about how FODMAPs cause no long-term harmful effects. They induce GI discomfort, pain, bowel changes during digestion, but once they've cleared the body, there's no persisting harm. However, I just listened to a speaker who suggested that there is sustained harmful changes in the gut for those with IBS who consume FODMAPs. The dysbiosis, immune activation, and impaired gut integrity seem like they would have long-term negative changes. I would love to know your thoughts.
I mean, that's not a quick question. So I don't know who the speaker was. I don't know what evidence they're referring to. The only harmful thing I have seen related to FODMAPs actually has to do with long-term adherence to a low FODMAP diet in terms of it's not great for the gut microbiome. I'm not sure how much evidence we have that consuming FODMAPs actually creates dysbiosis or impairs gut integrity. Like I'm not aware of that research, so I really can't comment on it. That's the first I'm hearing of this concern. So, what we do know, we do have evidence that one of the ways that the low FODMAP diet helps alleviate pain is it does seem to reduce histamine levels in the gut. But I don't know that it's a given that histamine levels in the gut are necessarily causing damage so much as nerve ending activation. Maybe they do, maybe they don't. I can't comment on that.
Thank you. Excellent. Yeah. Here we did have a couple questions on stool burden as well. So this one is, can you elaborate on the cause? What does it indicate? How to treat it? Maybe also any clues to identify it.
Jocelyn, have we did a FODZyme webinar on constipation?
Mhm.
You?
Yeah,
Is it on your website?
people can definitely look on that. I know you go into that in great detail there.
Yeah. I mean, it's literally an entire presentation to comment on what it is, why it happens. Stool burden is being full of stool. And it can be anything from slow transit to pelvic floor dysfunction to like having, a fiber overload diet, like a weight conscious, health conscious person who doesn't want to eat carbs and they're eating like 70 grams of fiber a day. There's a lot of reasons it can happen, but I would encourage you. I've done a whole hour talk on just constipation, and FODZyme has it for free on their website.
Great, thank you. Um, Here, this will probably be our last question because we are at time. Um, Lindsay asked, what do I do when I suspect SIBO and the GI doctor declines to order breath tests because they don't trust the accuracy? I've run into this a lot.
It's not, it's tough. I mean, like it's really what the patient should do, right? I mean, you can't treat SIBO. And you know, you can tell the patient their options, which is, look, I think that you have it. All I can do is help you eat to manage the symptoms. If your doctor doesn't want to test you for it and you want to be tested for it, consider getting a second opinion. Um, and, there's another question in here that was kind of similar, which is, what happens if, doctors don't believe in the breath test and they just treat empirically? A lot of doctors do that. The problem with that is that if somebody doesn't respond to antibiotics, which we know that 100% of people are not going to respond to rifaximin, even if they do definitely have SIBO, what often happens in those situations is the doctor gives you Xifaxan, you don't feel better, and they're like, okay, well, it clearly wasn't SIBO. Let's move on. And the problem is, well, what if it is SIBO? And we've just now taken that off the table when really the right answer is, no, 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 I did have SIBO, but it just wasn't Xifaxan responsive SIBO. And maybe if I'd actually had a positive breath test and I didn't respond to Xifaxan, maybe my doctor would have said, oh, all right, well, let's try something else then. Whereas if they're using response to antibiotics as a proxy for diagnostics, you're going to have a lot of people being told that they actually don't have SIBO when they might. And that's a risk.
Thank you. Um, well, we can't thank you enough for coming on today and sharing all of this amazing knowledge with us.